So are we ready to go? I can see myself. So as you were probably told, I'm a physician. So I work in public health, which really operates at the intersection of medicine and society. And so I was very happy to write the foreword to The Pandemic Divide, because there's no doubt that COVID has shown the existing inequities in our country. It replicated those inequities, and we are at risk that it will entrench those inequities. The kind of thinking that went into this volume are exactly what we need to hear in public health, despite the fact that this was a novel virus that no human being had ever encountered. We saw vastly different outcomes in terms of the risk of getting infection and the risk of getting very sick or dying from it, tracking along the hierarchy of our society and reflecting the power dynamics that have been in place related to the prevailing ideology of white supremacy. I was thinking that I would talk with Dr. Richardson, who wrote the afterwards, but I gather he'll be talking with you after. But I actually really want to lift up the importance of what he's going to say when he meets with you, that these inequities that we're talking about that result in so much suffering are not about making people miserable. They're about the system of government that is reflected in our economy, in the way that we think about people, and the way that our government runs, related to the extraction of profit and who wins and who loses in that. And our society has been, since its founding, stratified by race, related to the founding importance of enslaved African labor to the emergence of this country as a wealthy nation. But I think that there are some key points that public health can bring to this conversation. And one of them are the ideas that we use in epidemiology of exposure and susceptibility. Exposure meaning the likelihood that you get infected with the virus, and susceptibility meaning the likelihood that you'll get very sick or die from it. And we saw these from the very beginning, really stratified by race, ethnicity in the United States. We had the first person diagnosed with COVID in January of 2020. It seems so long ago now. And then we had already in March reports of vast excess of mortality in particularly the African American population. Subsequent waves have shown excess among the Latino population. And I do want to hasten to add that our data now show among the highest mortality rates among the indigenous people, who really bore the brunt of displacement and land appropriation and genocide with European settlement. So I think Black scholars too often don't acknowledge that, and I would like to add my voice. And the book itself is focused mainly on African Americans, and I'd like to just salute the importance of Black scholarship that's reflected in this volume. At least in my field, people who worked on Black-white disparities in health were really relegated to the edges of the profession of public health. Our papers were not published in mainstream journals. This has all changed a lot, but I really think that the vote of gratitude for scholars who struggled to get their work completed, get it published, and contribute to the discourse really needs to be acknowledged. Before I go any further, I also want to point out that the United States in general is in really big trouble, and that the life expectancy declines that we saw with COVID, nearly just on something about 2.5 years for the nation as a whole, over 3 years for Latinx people, the 3 years for people of African descent. Among indigenous people, life expectancy is now estimated at 65 years, a number not matched anywhere in our hemisphere except the country of Haiti. So we, as one of the world's wealthiest nations, have a sector of our population that can expect to live as long as people in Haiti who've been punished, frankly, for centuries related to their the first successful uprising of enslaved people in the modern era. So COVID came to us, and it showed huge inequities in the first wave. The data show that among young adults, the risk of dying for both Black and Latinx people was up to 9-fold higher. That was the number that we saw for 35 to 44-year-olds among Black people. And this was so early that it could only have been related to exposure. And the book talks about the ways in which the segmentation and partitioning of our labor market, our educational institutions, even our houses of worship, helped frame exposure. And this very high rates of infection and death at young ages related to workforce participation and housing arrangements is what accounts for the huge impact on life expectancy that we've seen. But I was going to say that the U.S. has been falling in terms of life expectancy since the 1980s. We were never in the top of the pack of wealthy countries, but since the 1980s, we've been falling in that pack, and our rate of increasing life expectancy slowed. And it's now been since 2017 that the United States as a whole has been clocking year-on-year declines in life expectancy. And that should be a warning because in a way, our life expectancies are how our societies function, written on our bodies. It's interesting to me that it has been received with so little alarm. But it is indeed alarming. A lot of times people talk about the impact of race really being ascribed solely to poverty, but this is not the case. People who are using educational attainment as a proxy for income, we saw that we couldn't make the race effect of COVID go away by accounting for educational attainment. And some of the observations when these data became available, and we still don't have as much data available from the CDC as should be available, the shocking fact that if all people of color had a life expectancy, the same rate of mortality as college-educated whites, we would have seen nearly a 90% decline in the mortality rate that has been experienced by people of color. So that's comparing to white college-educated individuals. That's quite a privileged group, but there's no biological reason that all of these should not, that we shouldn't all have the same chance. The fact is that that for somebody who works in health, as I do, to understand the impact that that we've seen from COVID uh, requires an engagement with the social sciences. And I would put to you that that's exactly what this volume has done. And in that sense, it's of interest to anybody who's concerned with public health, as well as economists and sociologists and people who think about educational attainment and so on. I thought I there so some a lot of this is something that we've all been observing for quite a long time. But I thought I would take a few moments, even though it's not going to be in the book, to talk about something that's been in the press lately, which is that we now, at this moment, and at a moment when we may be in the calm before the storm, we don't know what new variants may begin to circulate this winter. Last winter saw the Omicron variant emerge. The mortality rate among whites is now exceeding other groups. So some people have used this to suggest that the focus on people of color has somehow, left us uninterested and unwitting to the toll that COVID has taken in the white population. This has been covered in the New York Times and the Washington Post. And it really is the first time since the pandemic began that we've seen the mortality rate in whites as a group exceed that of other racial ethnic groups. But the data clearly show that every time there's a surge, we get a splaying again of the data, of the mortality and hospitalizations. These go up the highest among people who are African American or Latino or indigenous. As a new variant tears through the population, it would seem that there's still continued variation in both exposure and susceptibility that leads to an emergence of disparities once again. So with the Omicron variant in New York City, in New York State, I'm now the state health commissioner. And the Omicron variant with New York City, we saw a near, not a very big difference between the Black and white populations in terms of hospitalizations. But as Omicron surged through the population, the risk of hospitalization went up 2 to 1, twofold higher in the Black population as it is in the white population. So it's very important that we consider, first of all, the overall context, who's paid the highest price, whose lives have been disrupted, whose livelihoods have been disrupted, not just this period of several months in which we've seen a rise in white mortality rates, and that we also pay attention to the dynamism of this pandemic, which is not over yet, so that the observation now of excess white risk may not pertain. The explanation that has been offered for this has been the sort of emblem of defiance that vaccination and other public health measures has refusing vaccination and other public health measures has taken up in certain sectors of the white population. The data from Los Angeles County, which has made these data available, show right now that the highest mortality rate is in unvaccinated whites. But if you look at mortality, and it's marginally higher, it's not terribly much higher, but if you look at what's happened in the past, these vaccines aren't perfect, as everybody knows. They do help us avoid serious illness and death. But in the past, even there's been a higher mortality rate among the vaccinated of Black and Latinos as compared to whites. So, the understanding of the context remains a very important part of our understanding of this pandemic. People often say that it has pulled the curtain back on the structural arrangements in U.S. society, and that is true. And the book offers not only the problem, but suggests some solutions. So I think I've only talked for about 20 minutes, but I really don't have a whole lot more to say. And I have spared you my slides, but if you would like to see some of them, I'd be happy to show one or two.
I'm kind of winging it here. Yeah, no problem. Hang on, Dr. We've got some other questions coming up. Can you hear me?
Okay, sure. Hmm. Well, that wouldn't be my perspective.
I would not think it's your perspective.
No.
But do you think that a specific effort has to be, because it was politicized rather than with the vaccine and masking being politicized, does that make it also part of a structural or systemic problem?
Well, yes. So you're probably also familiar with the work by Ann Case and Angus Deaton on the whole diseases of despair, and the basic argument that while we were paying so much attention to people of color, which doesn't interest them much, and all of the problems that people of color have, we forgot about white people. And a similar narrative has come up about the observation. I don't know if I can show it. I don't think I can. The observation that at this moment, and this is really just in the past several months, there's a marginally higher mortality rate among whites. And certainly, I mean, this is me just hypothesizing, but certainly it seems likely that it's being driven by the resistance to vaccination that has become an emblem of defiance in certain sectors of the white population, particularly white Republicans. Are the least likely now to become vaccinated. There was a lot of talk early in the pandemic, when you remember vaccines were very hard to find.
Absolutely.
About how Black people were permanently, imprinted with the experience of Tuskegee and wouldn't agree to get vaccinated. When it turned out often that it was just really hard to find a vaccine. You had to be able to go on the internet, and you had to be able to go get off work, and you had to, get through many hurdles that working people would find impossible to negotiate, given the circumstances of their lives. And the Black-white disparity in vaccination really narrowed, and some of it in a way that, as a physician, I don't want to see, meaning that whites weren't getting vaccinated. So this politicization has to do with, this is not what I work on, but some people like Jonathan, can't remember his last name, think about whiteness and the ways in which people feel that they are losing ground, and that what they blame it on are people of color instead of blaming it on the escalating rates of income inequality, which are now beginning to affect a previously protected group.
Absolutely. And I think the other aspect is that they don't realize white people have always been dying from COVID.
Yeah.
You know, and I think because people get mixed up when it comes to understanding, when we talk about rates, the higher rates versus the crude numbers. And
Yeah,
I think
that's
that's,
true.
I
There are
think
more
that's,
white people in this country.
exactly. And so I think that's something
That's a
that
good point, too.
is also as part of the education that goes out, that people also
Yeah,
don't
but
understand
it's the
statistics.
rates now that I'm talking about.
Oh, yeah, of
So
course,
the
of course.
the most recent one was 6.9 per 100,000 to 4.7, the black-white difference. So, as I said, when the rates begin to escalate and spread to the population, we're in a sort of a lull right now. And I hope it doesn't go up again, but I assure you, we will not see that hold.
Yes, we have another question by Dr. Ossender.
Sure.
Commissioner, thank you.
You're welcome.
Okay. My question is so we have another subvariant of the Omicron sublineage out there, B2.75. We know that right now it's in about 0.5%, 0.7% overall population. We know that Delta variant started out the same way, and look at what it accomplished in terms of death and destruction across the world. And so what it means in terms of going forward, it means surveillance. It means being ahead of the game when it comes to fighting COVID. And again, when we say COVID, we're talking about the next variant that's on the rise. So in terms of surveillance, what do you think is important? I know people are looking at wastewater and trying to look at the development of COVID in populations, specific target populations. However, surveillance in animal species that can be infected with the SARS-CoV-2 virus is something that I think is important in terms of monitoring as well. What are your thoughts about that? What are your thoughts about how we are prepared for the next variant and for the next mutation that occurs in this virus that puts us on edge, and will we have to chase this virus with boosters?
Right, there's a lot there. So there are emerging variants. The 275 doesn't seem to be growing as quickly as some people thought it would, but there is another one, BQ1 and 1.1, which in the eastern United States now comprise about 20% of variants. The variant that the new bivalent vaccine, which I recommend, was really it's both for the original strain, the Wuhan strain, as well as the B5, but that one, which was up to 90% of all variants that we identified, is now down to about 60%. So it's declining and the others are rising, and there's another one that I'm not going to remember it's like in Singapore, which has a highly vaccinated population, which seems to be sort of tearing through that highly vaccinated population. So at this moment, the expectation is that the vaccines will protect more against serious illness, including death, than they will against infection. All of these Omicron family of viruses have mutated to become more immune evasive, meaning that they avoid immunity, whether it's natural, so people get COVID and get it again, or whether it's vaccine induced. Now, we, in New York State, we do monitor wastewater, which is a polite word for sewage. We do shed these viruses, and our observation is that we see variants, and you can find, it's technically not easy. There's huge volumes that have to be condensed to study, but we're finding that we only find identify the virus about 2 weeks ahead of the presence in the population. We are doing so much testing, and that the surveillance through testing has just has given us about just a 2-week lag behind surveillance of wastewater. I don't know anything about animal surveillance. We believe that we're not really even sure what the original host animal was for this virus before it became the pandemic that we've all experienced. So I don't know about, we all know that there were studies going on in the Wuhan laboratory that it became a source of some controversy, but I don't know anybody who's looking at animals. It's wastewater and surveillance of human populations. So you're right. We started out with B 4 and 5 just being a minority. They're rising. My understanding is that the BQ1 and 1.1 their doubling time is 2 weeks. So it does seem likely that we're going to see a new variant emerge. The question is, will it be more severe? And that we don't know. That would be bad.
Yeah.
I do want to say, though, that the vaccine does work. And anybody who hasn't gotten the shot since July is eligible for a booster if you've had the primary series, and you should get it.
Yes. One of the last comments I want to make is that when we look at the bivalent Omicron booster, we've seen less than 5% uptake since it's been available in early September. Again, some people feel that is demoralizing for the effort that went into generating this particular vaccine that we think is going to be, this is the first targeted vaccine that we've had.
That's correct.
What we had before was all designed against the original Wuhan strain of virus.
Correct. That's correct. The last number I saw was 7% of eligibles have received the bivalent booster, which, as you say, is the first one that's been tailored to a circulating variant. I just watched the debate between the two candidates for governor in New York, and the Republican candidate said, well, the vaccine doesn't do anything. And it's true that we all hoped that it would be like a polio vaccine. It would prevent infection, but it does not do that. But it absolutely has enabled us to see the declines in mortality that we have witnessed. And that counts. So I don't know what to say, except that people have felt disappointed with the efficacy of the vaccine, and just don't see the point in getting it because you can get COVID anyway. But that's not wise. But unfortunately, public health authority has been greatly diminished during this pandemic. It should have been a chance for us to shine, but instead, all of you social scientists can say more about how this happened. But it had a lot to do with the horrible costs that have been paid regarding people's livelihoods. And we're not finished with that yet. And public health was not able to protect people from that.
Thank you.
Thank you, and thanks for the opportunity to join you. Congratulations to all of the authors of all of the many chapters. I personally found really interesting the one on how people assess the risk of attending religious services, a source of resilience and support that they considered worth more to them than the risk of COVID. So those types of risk calculations are being done in the real world, and I appreciated the author of that chapter who exposed them for us. So, am I finished with my virtual trip to you all?